All right, good afternoon, everyone, and welcome to the Immune Deficiency Foundation's Lunch and Learn series. Today's program will explore Congenital Athymia 101 with Dr. Elena Hsieh. My name is Emma Mertens, and I'm the Program Manager of Community Relations at IDF. On behalf of all of us at the Immune Deficiency Foundation, I'd like to thank you for joining us today for this Lunch and Learn. We are so excited to host this webinar for the IDF community. IDF is dedicated to fostering a community empowered by education. We want you to remember that IDF is committed to our community, serving you as a trusted resource through the use of technology and innovation. We are here to give you the tools and information to become empowered and offer you our compassion, understanding, and support to emphasize that you are not alone on your journey. Today's Lunch and Learn is part of IDF's regular series of bite-sized programming that will provide diagnosis-specific information and support to our community wherever they may be. We'd like to thank our sponsor, Enzyvant, for supporting today's program, and we are excited to hear from them later on in the presentation. Before we begin, I would like to put out a few housekeeping items to keep in mind for today's Lunch and Learn. This afternoon, we are using the Zoom webinar feature. Attendees should be able to see the slides and our panelists when they come on camera and be able to hear myself and the presenters speak. Attendees will not be able to activate their video camera or their microphone. If you want to ask questions, there will be the opportunity at the end of the presentation. You are welcome to submit any questions you have for our presenters as you think of them throughout the session. Please type them in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember the information presented during this forum is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational forum or event. To learn about IDF and explore our resources, please visit our website at www.primaryimmune.org. The website offers a wide variety of online and printable resources for anyone seeking information or support for PI. This includes the Patient and Family Handbook for Primary Immunodeficiency Diseases, which features a chapter dedicated to complete DeGeorge syndrome. We can also help you find a PI specialist in your area with the Clinician Finder. Visit the IDF Resource Center where you can find all IDF publications, videos, news, and more. We also encourage you to check out IDF's Congenital Athymia website, which can be found at primaryimmune.org/congenital-athymia. The website offers information on thymus donation and links out to the Enzyvant Connect program, which we will talk about more in a bit. IDF also offers monthly programming and events. In addition to our Lunch and Learns, we host 2 IDF forums a month, and we also have Get Connected groups, peer support, and Ask IDF. We are also always thinking of ways to bring the latest in PI to you, such as the 2022 Primary Immunodeficiency Conference. We hope you save the date for this exciting event coming up on October 6th through the 8th. And now I am so pleased to introduce our presenter for today, Dr. Elena Hsieh. Dr. Hsieh is the Assistant Professor of Immunology, Microbiology, and Pediatrics at Children's Hospital, Colorado. Welcome, Dr. Hsieh.
All right, well, thanks for the introduction. So I'll go ahead and jump into our discussion topic today. I thought that it would be easiest to discuss congenital athymia in the context of SCID because albeit they are quite different. I think nowadays with SCID newborn screen, we're actually detecting most of the congenital athymia cases by newborn screen. So I thought I would start there. And you're all probably familiar with the story of the boy in the bubble and how this initiated the diagnosis of severe congenital immune deficiency and further therapies that have come from since then. The incidence of SCID is approximately 1 in 50,000 births, and it results in the defects in cellular and humoral immunity. Really, the key item for SCID is that there has to be severe deficiency of T cells, and then the B cells and the NK cells can be differently affected depending on the genetic defect. And as you all know, SCID is really a collection of different primary immune deficiency disorders that affect lymphocyte development. Typically, babies with SCID, similarly with congenital athymia, depending on what the genetic etiology is, they may appear quite healthy at birth, but they are a high risk for life-threatening infections. And in the setting of SCID, this is correctable with hematopoietic stem cell transplantation, as well as enzyme replacement or gene therapy. And this is in contrast with congenital athymia, where actually the treatment is thymus transplant. Therefore, it is quite important to make a distinction between the SCID diagnosis as well as congenital athymia, which can be often be quite hard to differentiate. So I will take you through some of the differences and commonalities there today. As a general overall description of how T cell generation, development, and function occurs, everything starts in the bone marrow, what I call the factory. And you have hematopoietic stem cells that then, depending on how they receive signals from these cytokines, then you can see the different cells further develop into T cells. And then T cells go to the thymus to become educated so that they can actually be selected to not react against self. And then once they are further educated, they leave the thymus and then go into the periphery to then be able to fight infection when they encounter microbes. And they can do that by secretion of cytokines, but also killing other cells. So in the context of T cell development and B cell development, these are the two unique cell types, the two only lymphocytes that actually have a very unique receptor, which is called the T cell or the B cell receptor. And the reason why we have such great diversity to be able to encounter multiple microbes and then have different responses to them is because we are able to generate a quite diverse T cell receptor repertoire or TCR repertoire that can recognize different kinds of microbes as well as different self-antigens. And here you have the picture of how the T cell receptor and B cell receptor are organized. You essentially have different segments of genetic material. This is called the VDJ, and the process is called VDJ recombination. When you undergo VDJ recombination, you essentially select different combinations of V region, D region, and J region, and then the parts that are not selected actually looped out into a little piece of DNA, and this is actually what is detected in newborn screen. As you can see in the process, for these pieces of DNA to be selected and cut out, there have to be many enzymes that are involved. And if there are defects along the way for any of these enzymes, that can lead to severe combined immunodeficiency. So here to our newborn screen, I'm based in the Children's Hospital, Colorado, and we handle the newborn screen program for SCID for Colorado as well as Wyoming. As I mentioned, the little piece of DNA that is looped out is actually what we seek to amplify in the newborn screen. So if there are too few of these genetic circles, it means that the T cell receptor did not essentially undergo recombination, and therefore that's a proxy for very few T cells to be in existence. In the state of Colorado as well as Wyoming, we typically have, it's a two-cart state. This is true also for for many other states. We do a first screen, and if everything is normal, it's great. We don't hear from those babies. However, if the screen is abnormal, we then have a retest. If the retest is normal, we also don't hear anymore. If the retest is abnormal, we make sure that this is not because of the quality control and then the poor material that was placed into the card. And if it's abnormal, we ask for a second screen, and then we follow up on that at our institution. So this is just a summary to kind of exemplify to you as to how newborn screening is performed, and then the follow-up we want to confirm, right? So if we do the newborn screen card and that's abnormal, then we want to confirm by flow cytometry. And it is here at this very key step where we actually make the distinction whether the patients have SCID or whether the patients have congenital athymia, because not only do we look at the number of T cells, but we also look at the number of B cells and the number of NK cells. So to be more clear, both in congenital athymia and skin, there's a lack of T cells. So we call that T minus. Okay. However, in the context of a skin, you can either have B cells or not have B cells. In the context of congenital athymia, you must have B cells because congenital athymia, it's a problem of the T cells only. In the setting of SCID, you can be B plus or B minus. If you don't have T cells or B cells, that means that then you have to ask the question about the NK cells. So if the only cells that you're missing is T and B, then you have a problem of BDJ recombination, which is the organization of the T and B cell receptor as I showed. And if you don't have TB or NK cells, then actually it's genetic defect that affects all of lymphocytes. And that's an example for 88 SCID, for example. Now, if you have missing T cells, but you have B cells and you also have NK cells, then we are now having to make the distinction of, is it a genetic etiology underlying a specific type of SCID that is T minus, B plus, NK plus, or is it a thymic defect? So today I'm going to focus on the genetic etiologies for thymic defects and really also on the therapy in the context of thymus transplant. So in the setting of diagnosis, this is very important, as I mentioned, to really understand whether the underlying problem is at the level of the thymus or the level of the bone marrow, because the treatment is very different. For one scenario, we do bone marrow transplant. For the other scenario, we do a thymus transplant. So if the newborn screen is abnormal, so that means that the TREC, which is the amplification of those T cell receptor excision circles, those little pieces of DNA that are cut out, are low. That's a proxy for having very few T cells. We verify that by doing flow cytometry, where we actually count cell by cell the number of T cells. And then if it's a T minus, B plus, NK plus, meaning that only the T cells are affected, then that's a scenario where possibility of congenital athymia or SCID that affects T cells only. Okay, so then we are in either this pocket or this pocket. If it's not T minus, B plus, NK plus, that is not congenital athymia. Okay, now if congenital athymia is possible, we then have other features that can help us really make the distinction. If there are additional syndromic comorbidities, that can be very likely congenital athymia, but we still need verification. And we often perform genetic evaluation at this stage. We can either perform a chromosomal microarray or a genetic panel or both, which is really in most scenarios, we approach both at the same time. And in a chromosomal microarray, you can actually detect pieces of missing of chunks of genetic material. So for example, 22q11.2 deletion is often identified in this manner. When you do a genetic panel, you're looking for specific genes. If you identify a gene that underlines SCID, then that's SCID and it's no longer congenital athymia. If you don't identify a reason for SCID, then that's still a possibility of congenital athymia. So then we go to the next stage and we can perform more extensive genetic diagnosis, such as whole exome sequencing. And oftentimes in whole exome sequencing, we can identify diagnosis of SCID or congenital athymia based on genetic etiology. If that is not the case, which actually often we find ourselves in that scenario, we have pretty much exhausted every type of immune phenotype and genetic analysis that we can perform, but we still, to make the difference, we can essentially, on a research basis, take bone marrow cells and then put it subjected under an artificial thymic organoid system. And really what that means is that we take cells from the bone marrow and we put it in a little petri dish that it's like a artificial thymus. So if you put the cells in an artificial thymus and they successfully differentiate, that means that if you had a thymus, then the cells could go on to become T cells. That means you actually have a missing thymus because you provided the exogenous in vitro thymus and then cells differentiated. However, if you put it in the thymus and nothing happens, then actually that tells you that the problem is that the hematopoietic stem cell process, and therefore that is SCID and we have to do a bone marrow transplant. So it is critical that we distinguish between a SCID diagnosis and a congenital athymia diagnosis. Now I'm going to go into thymus development and discuss some of the possibilities as to the genetic etiologies. I'm going to start with the sort of more 10,000-foot view picture and then move on into more specific details. So the thymus starts a development. It all starts at the third pouch of the third segment in the pharyngeal pouch. And here you have the colors described in this key here. As you proceed in the fetal development, here the thymus and the parathyroid derive from the third pharyngeal pouch. And then there's further development that occurs along the line. You can see that the thymus places essentially very close to the front position of the heart, and the parathyroid position themselves next to the thyroid. So if we then take a zoom and close-up picture here, and we look at the third pharyngeal pouch, and then we decide as to what are the genes that can be involved in congenital athymia. Those are the ones that would affect development on the thymus. And we have essentially two broad categories. They're either genes that impact development of the thymus specifically, or they're genes that impact just development of the structures in the midline. The structure of the midline, here are the genes that are listed there. And then if here are the genes that are listed for specific defects that affect thymic development. So now we're going to zoom in the next stage and now look at thymic development. Thymic development can be divided into two stages. There's either a FOXN1 dependent and a FOXN1 independent stage. Okay, so I'm coming here. This is the thymus. And as the thymus needs to develop, there are different genes and transcription factors that need to be turned on. And FOXN1 is one of the critical ones. So in the first stage, that is FOXN1 independent here in the third pharyngeal pouch, then you actually have these genes that need to be involved for the further development and separation. And then when you get to the next stage, which is the FOXN1 dependent stage, here you have thymic epithelial cells that need to be differentiated and developed for them to actually nurture and interact with the T cells so that they can successfully be educated. And that stage is actually fairly dependent on FOXN1. So in a sort of big overview of embryogenesis, if we start from beginning to the end to the most differentiated, if we're looking at defects that essentially affect the very early development, we can have problems that are associated with the midline, specifically the genes listed here. As you go further along the line, recall that I mentioned some parts of thymic development specifically are FOXN1 dependent, so this comes on later, these defects. And then there are possibilities of problems with air. Air is a gene that is important for the thymus to actually show pieces of self to the T cells so that the T cells can be educated and understand that they do not need to react against self-antigen. Okay, so I'm going to spend a little bit of time focusing on a couple of the genetic defects, one of them that lead to congenital athymia. So remember, congenital athymia, we're dealing with T minus, B plus, NK plus. So B cells and NK cells are fine. T cells are the only ones that are defective. This is often nowadays picked up in newborn screen, where you actually have an abnormal newborn screen. Then you have to differentiate between what are the different etiologies, whether it's a SCID or there's a congenital athymia. By the time you know it's congenital athymia, we're now doing genetic studies. And FOXN1 deficiency is the first genetic defect I will discuss. In the context of FOXN1, now we understand that there are several types of mutations. They're homozygous, meaning that the two copies are affected. So we often have for every gene a copy for mom and dad. Homozygous means that the two copies are affected. Compound heterozygous means that the two of them are affected, however, the mutation is different. And heterozygous means that only one of the copies is affected. In the context of homozygous patients, and that applies to also compound heterozygous, because in either scenario, the two copies are affected. These patients typically manifest significant immune deficiency, so they fail the newborn screen. And therefore, patients have significant susceptibility to infections that you typically find if you don't have T cells, and that's pneumonia, chronic diarrhea with failure to thrive, fungal infections, mycobacterial infections. Then FOXN1, it's important for also hair and nail development. So we often find alopecia and also nail dystrophy. So those are depicted here. It's a picture of alopecia, and this is a picture of what nail dystrophy looks like, which is essentially poor development of the nail bedding. And in the context of immunological defects, we have very, very few T cells, particularly CD4 T cells. As I mentioned, they fail newborn screens, so very, very few TREX, very few naive T cells. And then we often have the very few T cells are in existence, they have a memory phenotype. And that can lead to then the manifestations of Omen syndrome, which essentially is the patient's own T cells, whatever it's remaining, that it's in the memory phenotype, can then attack self. It's a little bit of kind of like if you receive a transplant and then you have the donor cells attacking the host. This is actually the own host cells are attacking the host, and we call that autologous graft versus host disease. We often see that in congenital athymia because if we have a few T cells remaining, they tend to have an oligoclonal repertoire. So repertoire is the diversity of your T cell receptor. So you have a very non-diverse T cell receptor, and then you have very few T cells, and they tend to be the ones that actually attack self. We then, these T cells tend to be not very responsive and don't proliferate well. As I mentioned, the T and the N, and as I mentioned, the B and the NK cells are typically numerically normal. However, the B cells, to make antibodies, they need T cell help. Therefore, if you don't have T cells, they cannot help the B cells, and that results in the inability to make antibodies. So patients with congenital athymia need to be on antibody replacement because of the problem with the T cells. As I mentioned, you can also have patients that only have one copy of genetic material that is mutated in FOXN1. They often have problems with alopecia and the nail bed also, but their immune deficiency tends to be more mild. And they may show low, but not as low as number of TREX compared to the homozygous patients. And a lot of these patients will actually normalize their number of CD4 T cells as they grow older, or that their CD8 T cells remain persistently low. I'm going to now move on to DiGeorge syndrome, or short DGS for short, or also it's referred by many other names: velocardiofacial syndrome, also catch-22, also 22q11.2 deletion. And in this scenario, we have a deletion of this area. This is often detected by chromosomal microarray because it's a chunk of DNA material, not just one single gene. Is de novo in most of the cases, meaning that actually appears for the first time in the child and it's not identified in the parents, and is autosomal dominant in a very small fraction of the cases. DiGeorge syndrome can have a really, really wide immunological spectrum, from partial, meaning that the problems affect the structures of the midline, but it's a very mild defect, going all the way to complete, where there's no thymus at all. And it is in the setting where there's no thymus at all, that then we're in the congenital athymia category. Again, the spectrum is really wide. So if the T cells are present and they work mostly, then they might not have problems with antibody production. But if the T cells are severely affected, then there will be problems with antibody production. Patients often also have autoimmune and atopic complications, and this is manifested here, as well as an array of different other congenital anomalies. That can be a conglomeration of heart defects, parathyroid problems, which result in problems with calcium metabolism, calcium regulation, and then facial dysmorphism, also cleft palate abnormalities, which then altogether results in feeding difficulties, as well as development problems with development of the genitourinary structures, because they are structures of the midline, and often associated with psychiatric disorders as well. So in this area of 22q11.2, there is this very specific gene that is called TBX1. And TBX1 is part of these 30 genes that are in this region. If there is only TBX1 gene that is deficient, that also essentially is going to lead to a picture that is very, very similar to DiGeorge syndrome. So that's why I like to talk about TBX1 in the context of DiGeorge syndrome. TBX1 is just one of the genes that is part of this 22q11.2 region. Now, in embryogenesis, this is actually pretty important in the development of the third pharyngeal pouch, where, as I described before, is really where thymus and parathyroid development occur. The other gene that also we'll discuss is PAX1 deficiency, which is associated with otophagocervical syndrome type 2, or OTFCS2 for short. And in this context, this significantly also affects the thymic development. That's because it has a very specific role in the thymic epithelial cells. And in short, essentially, the thymic stroma is affected, and therefore it cannot properly interact with the T cells and nourish development. And therefore, we also have problems that result in T cell lymphopenia. And they can be also a fairly wide range of immunological and clinical abnormalities, depending on the severity as to how PAX1 is affected. The last genetic defect that I will talk about is Chart syndrome, and that is due to haploinsufficiency, means that only one of the 2 copies is affected of this gene, which has a really long name, chromodomain helicase DNA binding protein, or CHD7 for short. And CHD7, as I mentioned, the defects here that lead to Chart syndrome are actually affected with problems of one single copy. And this is an illustration of all the different jobs that CHD7 has. It has a job that is important for heart development, ear development, cerebral development. And therefore, if there's a defect in CHD7, there'll be defects along the embryogenesis of every one of these organs, which is how we see the manifestation of charge. It is currently thought and hypothesized that CHD7 has an effect on TBX1. And as I mentioned before, TBX1 is in this area of 22q11.2. And therefore, this is how and why the children with Chart syndrome can also have problems with thymic development, and some of them may even have thymic aplasia completely. So Chart syndrome consists of manifestations of coloboma, heart defects, atresia of the QNA, as well as growth retardation and genital abnormalities, ear abnormalities, all in the context of really the jobs the CHD7 has for embryogenesis and development of the different organs. So if there's a defect in CHD7, it will affect all of these different organ development. CHD7 deficiency is also associated with actually its role on the regulation of other genes that are important for immune function, and mentioned here, Ikaros and IL-7 receptor. But most important and pertinent to our discussion today, the studies that suggest that CHD7 regulate TBX1 expression, and this is why we end up seeing the effects that it has in thymus. Again, a really, really wide spectrum of really the types of T and B cell defects that we can have. So as a table summary here, I think as clinicians and practitioners, some of the things that we focus on, we definitely like to look at the labs, and we do a lot of immunophenotype studies, meaning that we care about how many lymphocytes are there, T cells, B cells, NK cells, what's the phenotype of them, meaning do they look like naive cells, do they look like memory cells? But we also look at the effect on many of the different congenital anomalies that we see beyond the immune cells. And this is a summary of the genetic disorders that I have discussed, and really the additional features outside of the immunological defects that I have discussed. How does it affect facial dysmorphism, any cutaneous alterations, and we mentioned the alopecia nail dystrophy for FOXN1. Really, how does it affect the heart development, the context of the infections, which really that's the commonality for really all of them, where you have increased susceptibility to viral, fungal, and microbacterial infections. And then based on the different syndromic features, we might be able to get a hint of which of these different genetic disorders underlies the etiology for the congenital athymia. This is another table that summarizes the genes defects that I have discussed, specifically describing what their role is in different parts of thymus development and embryogenesis, the associated conditions and really the syndromes that they usually result in, and then the non-immune manifestations, which is actually best summarized in this picture. But this is really a good summary table of that. So I will end there in the context of genetic etiologies for congenital athymia. And I think I don't need to really explain to this audience, very well known, that immune deficiency of any kind has a significant emotional social burden in the family. But we recently published last year really some nice data from survey from families of children with congenital athymia, the emotional social burden of this diagnosis on the families. And you can see here that when there is no thymus and therefore there are no T cells and there's a really significant susceptibility to infection, it can be quite socially isolating and a great burden to the caregiver because of the risk and the concern for infection. Again, going to sort of how I opened the discussion today with the story of the boy in the bubble, that is really not that different for congenital athymia. There's significant financial hardship in being close to a tertiary center, also hard, difficult inability to work, and really all the impact that it has in the other family members, the friends, the siblings. In addition, also because there is a context of trying to maintain the child isolated and really decrease risk of infection is really quite challenging to be able to socialize with other families, especially for the siblings of the affected child, and really how to plan for future. And that is also not to mention all the clinical implications of having congenital athymia with the number of procedures that our patients undergo, the number of hospitalizations, the number of different imaging studies is really quite significant. So we have then by now discussed the different, so how to distinguish SCID with congenital athymia, where we're really only concerned about distinguishing congenital athymia for one single type of SCID, which is the T minus, B plus, and K plus. Then we further discuss in the context of congenital athymia how the thymus develops, how it really is in the center, and it derives from the third pharyngeal pouch development. And that if there are genetic defects that affect the midline, that can affect the thymus. I like to say the thymus is an innocent bystander in that scenario, or they can be genetic defects that are very particular to thymus development and only thymus development and do not affect other structures of the midline. And we only really have the scenario for FOXN1 in that case. So now that we've gone through the distinctions of the clinical picture of SCID and congenital athymia, the genetic etiologies of congenital athymia, the impact of the congenital athymia diagnosis on the social and emotional context, we're now going to discuss, I'm going to spend some time talking about the treatment for congenital athymia, which, as I mentioned, the reason why we care about the differentiation between the diagnosis of congenital athymia and SCID is because the treatment is different. For SCID, we want to perform a bone marrow transplant. For congenital athymia, we want to perform a thymus transplant. And the reason why thymus transplant works is because, as I mentioned, the thymus is the home of education of T cells. T cells start being made in the bone marrow. They reach a stage at which they have to go and get educated, meaning that they go into the thymus so that they're told what is self and what is non-self. So you start here from the bone marrow, and then you go into the thymus. And then in the thymus, you start with being a double negative cell, which means that you're not CD4 positive or CD8 positive. Then you become double positive. You interact with many of the very important cells in the thymus. They're structured in the thymus called the cortex and the medulla. And then it is by interacting with this, what I call the nurturing cells, or really the thymic epithelial cells, that then the T cells become educated and further develop, and then they mature, and then they leave the thymus. So in the context of thymus transplant, in 2021, Rethymic was approved, which is allogeneic processed thymus tissue. This is a thymus implant, and I will let the Enzyvant folks talk to you more about that. But I wanted to mention that if you're wondering how the process works, the thymus implantation, the thymus essentially from donors is processed in a very particular way, which I'll take you through some of that. And then this is implanted in the thigh. You can show here, this is strictly from the FDA prospectus. And then the rethymic slices are implanted in the individual in the thigh. And then this is close, and then we essentially wait for the thymus for the lymphocyte reconstitution. So let's start by talking about where the donor tissue comes from and how this thymus tissue is processed. So donor tissue is obtained usually from healthy infants. If you recall the picture of thymus development, the location is right in front of the heart. Therefore, when heart surgeons go on to repair cardiac defects, that is actually often discarded because it's in the way and the surgeons need a better visual field. So then that tissue is taken. Then the removed thymus, then it's cultured for 13 to 20 days before the transplantation so that we can remove the thymocytes while preserving the thymus stroma. So we don't want the thymocytes from the donor, right? Those are the ones that are going to be different than the recipient. We want that very nice, what I call the nurturing cells that are the thymic epithelial cells that belong to the thymus stroma, which is really the home of the T cells that are going to be educated. Then this process has been shown to be consistent in between different slices of the thymus and different kinds of thymus culture. We want to remove, again, the donor thymocytes, which are the mature T cells. However, we do maintain some of the viable CD4 T cells. The stromal cells are largely preserved, and these are the cells that we care about to then be the home for the immature T cells that come out of the bone marrow of the recipient. And then depending on really how the histological evaluation looks like and screening for any of the infectious agents, then these are implanted into the quadricep muscles of the recipient as I showed you in the picture. Very important, and this is different from bone marrow transplant. The thymus donor tissue does not need to be matched to the recipient. Okay. Now, I've talked to you about the donor's tissue. What about the recipient, and what are the indications for the patients to receive thymus transplant? Because that has to be fairly stringent, as thymus transplant is not the treatment for every immune disorder, right? So it has to meet criteria for congenital athymia. So what does that mean? Does that mean to be eligible? It requires the diagnosis of complete DiGeorge. So if you have complete DiGeorge, you have no thymus. And that could be either with or without a genetic diagnosis. You have to demonstrate evidence of extreme T cell lymphopenia, meaning very, very, very low T cells and very, very low naive T cells with a specific number shown here. Clearly, you can also have other reasons for congenital athymia other than DiGeorge, and those patients are also eligible as long as they meet this criteria of the number of very low T cells. Sorry. So where does the data come from? As you know, as I mentioned, this became FDA approved in 2021. However, thymus transplant has been studied for quite a few years, and this is a study that summarizes a patient and data and studies from 105 patients receiving a culture thymus transplant or implant. And this is a study that is out of Duke with Dr. Marquette. This encompasses patients that have been receiving transplants from 1993 until 2020. And as shown here, we started with 105 patients receiving transplant, and 95 of the patients are actually the ones that underwent a full analysis for who received then transplant for congenital athymia. 63% of them completed the study, and I'll show that, which is basically 2 years post-transplant. 21% discontinued due to death from that, and then 6.7% are actually still ongoing post 2 years. So I want to really spend the next amount of time summarizing the study because I think this is the most complete study that we have, and really the data from which it was based to actually attain FDA approval. First of all the patients had to meet diagnostic criteria for congenital athymia, and that was to find that if you have complete DiGeorge syndrome, that's either with or without a heart defect, or if they have FOXN1 deficiency, or if they have any other genetic defects by which they prove that they have congenital athymia. How do you prove that? That is by the number of T cells that are actually detected in the periphery, meaning by a blood draw. And there was exclusion criteria, and that has to do really with the comorbid, meaning the other health problems that the patients had. For example, if it was heart surgery within 4 weeks of administration of thymus, then that was the patient would exclude it if they were a poor surgical candidate, if they couldn't undergo anesthesia, if there was HIV infection, or if there's CMV infection. Now, as I mentioned before, many of these patients, if they have a few T cells, they tend to be in the memory phenotype, and they actually attack the host. So they have this autologous graft versus host picture. So those cells are actually attacking self, need to be suppressed, which I know sounds very counterintuitive for someone that doesn't have any T cells to be further immunosuppressed. But you don't want any of those T cells that actually react against self around. So immunosuppression is given to those patients on the basis of really how well or how poorly the T cells proliferate to PHA, and they're given rabbit antithymocyte globulin, either alone or with calcineurin inhibitors, to make sure that none of those T cells are actually self-reactive are around. And then here is the table of the baseline characteristics of all the patients that underwent this study, where you can see the average age of transplant of the patients, the difference in terms of sex, and a breakdown of ethnicity. And if you look at the diagnosis, really, by and large, most of the patients, most of the patients had 22q11.2 deletion, but there's certainly patients also with Chart syndrome shown here with CHD mutation, as well as FOXN1. This is the different summary of the other comorbidities associated with the defects of the midline. And as I mentioned, completion of study is usually 2 years post-study, which means 24 months. And this is the Kaplan-Meier curve of survival. And you can see that survival is it's roughly around 80% post-transplant, and maintains all the way out to 25 months. Then here, in the context of how does the lymphocyte recovery occur, typical phenotype means that meeting the criteria of the significant low number of T cells. Atypical phenotype typically means if there was actually Omen syndrome that was significant and present. And you can see here the different lines indicate the absolute lymphocyte count. So that's your total lymphocytes. The green is the T cells, the orange is the B cells, and then the blue is the NK cells. And you can certainly see the reconstitution as months after the thymus transplant occurs, and how that recovery takes place. So we looked at the number of T cells, and this is another illustration where we then have the further breakdown. So here is lymphocytes, T cells, B cells, and NK cells. Then we are looking here at the breakdown of total T cells in the dark blue. Then in the lighter blue, there's the alpha beta T cells, which comprise the majority of your T cells. As you can see, is very close to the dark blue line. Then we have the CD4 T cells in green, and then the CD8 T cells in orange. And you can see that pretty much by after 12th month, the reconstitution is quite good and remains. Then we have the breakdown of the naive T cells, or the memory of the baby T cells, that attest to the fact that the thymus is actually working and providing the appropriate home for the naive T cells to leave and go into the periphery. And you can see quite the recovery that you see the numbers increasing around the 12th month time point. And then, as I mentioned, in immunology, we care about the number of T cells, but really also about their function and how well they proliferate. And here you can see that the green light is how the T cells respond to tetanus for control cells. So meaning these are not patients that receive thymus transplant, but actually healthy people, and really how good the proliferation is. And then you compare to that how well the T cells proliferate of the patients that received the thymus transplant. And you can see that their response to PHA is shown here, and you can see that response to tetanus toxoid is also quite good, and past 12 months is, well, I would actually argue past 6 months is where we'll start seeing recovery of the proliferative capacity. So you start reaching fairly good numbers at around 12 months, but as shown here, the numbers start increasing around 6 months, and right as the number increases, you also see the proliferative capacity to be increasing around this time also. In the context of adverse events, here is a summary of them. And typically we did have some drops in other different cell lines, including thrombocytopenia and neutropenia. And here are the different skin manifestations that we're able to see in the context of post-congenital thymus transplant and the administration. Here is a summary of the number of infection of 6 to 12 months post-transplant compared to 0 to 6 months and 12 to 24 months. And you can see that as time goes on, there is a decrease of number of infections that occurs as the T cells begin to reconstitute. And lastly here, like with any transplant, including bone marrow transplant, there's a chance of mortality. And here it indicates the causes of death with respect to number of days post-transplant, and then the reasons for which that happened, with essentially respiratory failure and sepsis being the majority of the cases. So what is the future of thymus transplant? I think, as I mentioned before, currently the way the product is made is with donor tissue that is harvested from infants undergoing cardiac surgery. You do not need to HLA or haplotype match as you do for a bone marrow transplant. And I think in the future, the idea is to actually use some of the biological technologies that we have to better engineer thymus tissue and better design these thymus epithelial cells so that we can actually have a better prognosis and really less standardize the process of thymus transplantation and even getting to the point of quote off-the-shelf product where that can be cryopreserved and engineered for better accessibility, better availability, and faster expediency of access to thymus transplant. I will end with the note that we should think about thymus transplant. Clearly, it is a treatment for congenital athymia. So if you don't have a thymus, well, you can reconstitute and give a thymus back to the patient who doesn't have that. However, going back to what the job of the thymus is, recall that the thymus is the home to educate the T cells so that they can become knowledgeable to distinguish what's self and what's non-self. So if we think about other transplants and what typically happens, so with heart transplant, kidney transplant, and any other organ transplant, patients often need to be immunosuppressed for life because you are constantly worried of the rejection and the interaction that can happen between the donor organ and the recipient and the host. So if we actually can make thymus transplant easy, accessible, successful, and expedient, we can actually perform thymus transplant as a way to promote transplantation tolerance, meaning that we can perform that as a stage before solid organ transplant so that it can actually facilitate the tolerance of the acceptance of the donor organ. And I think that's very exciting and really expanding the use of thymus transplantation beyond congenital athymia. I will end there. I think that's about 10:48, leaving time for questions and the additional presentation. Thank you very much for your attention. This is a picture of my lab. I'm based at the University of Colorado, Children's Hospital, Colorado. This is our clinical team. We are 4 clinical immunologists, and we have additional transplanters who are very familiar with bone marrow transplant. This is my lab, and we do basic science research on primary immune deficiency and inborn errors of immunity, including those genetic disorders that lead to athymia.
Good afternoon, everybody. My name is Johanna Rosel. I'm the Chief Commercial Officer at Enzyvant. We are very excited to be here today to give you an update of what we have been working on for rethymic and to talk about our program, Enzyvant Connect. So I just want to complement what Dr. Helena has said about Rhythmic, and as being a pharmaceutical company, talking about the value of our asset, we also need to make sure that we cover our safety information. As cover, Rhythmic is indicated for the immunoreconstitution of pediatric patients with congenital athymia, is not indicated for SCID. Very important to know that it takes time for the immune reconstitution to happen in these kids, which is needed for protecting them from infections, and it could take between 6 to 12 months, and only your doctor is the one that can give you guidance on when is the right time and the right treatment that needs to be done in the meantime. I think it was covered also, but just to highlight, as everybody knows, there were many kids that went through the clinical trial. We enter the picture to work with the institution that was creating the, generating the treatments and doing the data to make sure that the clinical trials, the last 2 clinical trials, were acceptable and something that the FDA will approve for Rhythmic. The goal of this is to create a long-term view of how to treat these kids in the future. So in general, what you will see through my presentation is related to our quest to create a sustainable way to treat the children with CA. As many of you maybe know and recall, the first time that we tried to get approved by the FDA, we received a CRL, and it was based on the manufacturing and making sure that we had the highest standards that the FDA requires for their products when they are approved. I'm going to cover a little bit more of this in the next slide, after the safety. And I think Dr. Helena also talked about what is it? It's surgically implanted in the leg of the children, and also cover a lot about like the goal is to generate the T cells that are going to protect the kids. Let me real quick cover the safety information. As you can see there in the link, you can get further information on the safety data of Rhythmic, but here we summarize the main safety concerns that you need to take into account when treating a kid with Rhythmic. And the first one is graft versus host disease. Then there are a series of autoimmune disorders, kidney disease, potential cancer, transmission of serious infections. You should not vaccinate the kids until the doctor determines that it's the right time to vaccinate them. She also covered part of this information with HLA typing. There were deaths in our trials, and the most common side effects were hypertension and renal impairment and graft versus host disease, as I said before. These are not all the safety concerns that you should have when treating the kid with Rhythmic. The doctor would be the right person to determine and follow up on the months after the treatment. So if we go into how Rhythmic is made, it goes beyond a transplant. Rhythmic is engineered between 12 to 21 days, and it's processed to make sure that it has the right components to be able to do the implantation in the leg of the children. And this has complex manufacturing. As I said before, our first rejection from the FDA was because of manufacturing, and we needed to work with the institution to make sure that now we have the right pathway to treat them with the highest safety and efficacy standards that the FDA comes with. What had happened since the approval in October, we also got approved by our company to be able to build a new manufacturing facility that will allow us to do more long-term treatment for the kids. This will take between 2 and a half to 3 years, but because of the complexity, we need to start working today to make sure that this happens in time for having this pathway where every kid that is born with CA has the possibility of being treated, versus in the past where clinical trials having 5 to 6 kids only treated in a year. I think it was covered also that the complexity is not only the manufacturing, but also we need to receive the thymus from kids that are less than 9 months old, and also working on a pathway to make sure that we always have the right amount of donor thymus to create rethymic. In terms of the support that we are providing, and before I get into Enzyvant Connect and the details, I want to make sure that you know that we work really close with the institution, and as if was slow at the beginning because of all the different components of the healthcare providers and the healthcare system that needs to be aligned for a new way of treating kids. One treatment that happens only once and it's not monthly. The reality is that we have gotten excellent feedback from payers, from different key stakeholders, in the fact that Enzyvant really is not only trying to help these kids for a couple of months or something like that. It's like the possibility of changing the lives of these families and caregivers. The value that we offer with the strong data that we were able to support, to create, has given us the opportunity to activate the treatment of the kids. And I'm sure a lot of people know we already have treated 3 kids and are very positive about the activation that is happening at the institution to continue to treat kids. It took us a while, but now I feel that the education is in the right places of everybody that needs to support it for this to happen. With that comes also Enzyvant Connect, which is our program specifically to help the patients. We help them in 2 areas: educate caregivers, education, and the reimbursement support. As I said before, very positive feedback, but this is combined with the work that the institution does on getting the full picture of how the kids will be treated and the support that they need to have after is what Enzyvant Connect offers. Here you can see our website and also our phone number, where people that we already have many families being part of Enzyvant Connect, and you will receive support from what CA is to the process to like get education on how the resources could be used for the reimbursement, and if copay or other supports are available for you. With that, I think I cover my 5 minutes. I try to do as concise as possible, but please feel free to access Enzyvant Connect or call for extra support. Thank you.
Can you please talk about lack of sustained response to MMR and other vaccines? For example, initially a high titer, but negative again within a year or so. Thus, if the test is not repeated, the assumption is that they have ongoing protection from the vaccination. Let's see. Can you address, the different types and vaccine response?
Yeah, so the situation with MMR is a little different as in, so I'll start that assessment of vaccine response. Usually you want to look at the titers in the context of IgG production. And that is a proxy for you got enough T cells reconstituted to talk to your B cells to then make antibodies. You can also, however, assess directly the T cell response by looking at T cell proliferation in response to those antigens. So you can look at T cell in response to tetanus, for example, and that is another way to assess that. I will say that if for MMR, it is one of those vaccines that even in people that have a normal immune system, when they get assessed for MMR immunity, it's often equivocal and actually declines over time. So some vaccines are more robust to inducing a long-term immune response versus others, and MMR is notoriously not great, along with hepatitis B. The other thing also, MMR, it's a live vaccine. So actually the threshold and the criteria for when patients that have been transplanted can receive live vaccines is drastically different than receiving something like tetanus, for example, which is a kill vaccine. So please keep in mind that we care about when is the right timing to give the vaccine, live versus kill, and then really the type of vaccine and the assessment on titer. So for things like Hep B and MMR, which notoriously we know even in normal immunocompetent people, the response is poor and declines fast over time. We do recheck titers, but the timing of recheck is not standardized across the nation.
Wonderful. Thank you so much, Dr. Hsieh. And it looks like I think everyone else's questions have been answered. So thank you. You're so on top of it. And I think the other sentiments expressed in Q&A were just appreciation for your presentation and for all this great information. So thank you so much again, Dr. Hsieh. And thank you again to Enzyvant for supporting this program today, of course. All right, so we hope that you'll remember to take advantage of all of the resources that IDF has to offer. Again, if you're looking for materials or information on congenital athymia, you can visit any of the links on your screen. You can visit our website and search congenital athymia in the search bar. We have tons of resources at the IDF Resource Center. We have educational videos, countless resources, and opportunities for connection within the PI community. So we definitely encourage you to check that out. And to our audience, if you had other questions you wanted to ask today, we definitely encourage you to ask IDF. You can go online and submit your questions to primaryimmune.org/ask-IDF or give us a call at the number on your screen. And we want to close by saying that all IDF programming is truly guided by the individuals and the families we serve. And so therefore, we hope you'll take our very brief program evaluation survey, which we will email out to all participants after the webinar. And lastly, we hope that you will join us for our next program, which is actually tomorrow, the SCID Compass Summit, which is happening tomorrow and Friday from 11 to 3. You heard a lot about SCID today in this program, so if you want to learn more, definitely join us tomorrow and Friday. And then our next IDF Lunch and Learn will actually be on August 24th, where we will explore APDS with Dr. Evelyn Wu from UNC Children's at Raleigh. Thank you so much again, Dr. Hsieh and Enzyvant, for your support. Thank you everyone for your engagement today with your chats and questions. We really appreciate it. We appreciate you joining us and hope to see you at the next IDF program. Have a great rest of your day.